Our first speaker today is Dr. Katie Spangler. Dr. Spangler joined Marshfield Clinic in 2013, where she almost exclusively sees patients with movement disorders, the majority of which have Parkinson's disease. She sees patients in Wausau, Weston, and Minocqua. She's been involved in investigational trials, including the FDA-approved Duopa for Parkinson's disease. She also has a passion for Huntington disease and is a member of the Huntington Study Group and the Parkinson's Study Group. And we're really proud and honored that she's a member of the WPA's Medical Advisory Committee. Welcome, Dr. Spangler.
Thank you. Good morning. I'll say welcome to everybody and good to, see you. So today, let me just get this screen a little bigger for me. So today I'm going to be talking a little bit about the non-motor symptoms. Next slide. So the first part is primarily going to be talking about, again, these non-motor symptoms of Parkinson's disease. I hope to cover some of these symptoms that you may be having, but you don't think about to ask your provider about. And then I'm going to talk about different ways we can manage those symptoms and maybe tips to help cope with them. We'll have some time at the end also for some question and answer. The motor symptom management will be talked about by my colleague after mine, Kelly Brandt. Next slide. So just real briefly, I'm sure most of you have come across this in some way throughout your journey. The four major motor symptoms of Parkinson's: resting tremor, stiffness, slowness, and then gaiter balance. As you know, we test these four major symptoms through a scale that we use in clinic called the Unified Parkinson's Disease Rating Scale. Next slide. You also know that these motor symptoms are primarily treated with dopamine, whether we're giving your brain back dopamine, using what you have better in the brain, or whether we inhibit the breakdown of dopamine in the brain. I wanted to just bring your attention, there's a newer medication in the upper left of the slide that works a little bit differently, but still somehow works with the dopamine pathways. So again, when we talk about motor features of Parkinson's, that's stiffness, slowness, balance, and tremor, we primarily are treating those motor symptoms with dopamine. Next slide. So what are these non-motor symptoms? Well, I have them listed there. Non-motor symptoms. So these are symptoms that we can see in people with Parkinson's disease. And as mentioned earlier, though, we don't always treat them with dopamine. What are some of these non-motor symptoms? We see mood, so depression or anxiety. We see apathy. We see cognitive changes. We see what we describe as autonomic symptoms. Autonomic is a part of the nervous system that helps regulate blood pressure, bladder function, bowel function, sweating. You also can have hallucinations or delusions. You can have impulse control issues, a multitude of sleep issues. This can include insomnia, trouble falling asleep, trouble staying asleep, restless leg syndrome, periodic limb movements of sleep, which are basically jerks in your sleep that can cause arousals, sleep fragmentation, which basically is just as we go through our sleep pattern, we have a certain pattern, but people with Parkinson's don't always follow that pattern, and it's fragmented, and they can have more frequent arousals. REM behavior disorder, vivid dreaming, and even apnea. Pain can be a non-motor symptom, fatigue, smaller handwriting, which is probably part more of the bradykinesia, speech, swallowing problems, dizziness, vertigo even, breathing difficulties, weight loss or gain, and then skin changes. So as you see there, I have some asterisks by them. Some of these I won't be able to be talked about just because of time constraints, but there will be a question and answer period. So if you have specific questions about those, I would encourage you to do that later. Next slide. So first, let's touch on mood or anxiety. So reports up to 40% of patients with Parkinson's will have some anxiety. What is anxiety? Well, it's a feeling of constant worry or nervousness that goes really beyond what is understandable. It actually is a part of the disease itself. There's actually chemical changes in the brain that are happening as part of Parkinson's disease that is causing the anxiety. It is not thought to be tied to disease progression. So anxiety can present itself early in the disease or late in the disease. There is somewhat of a tie, however, to motor fluctuations. It seems that patients who seem to fluctuate, and again, when you're on carbidopa-levodopa over time, you may develop motor fluctuations. And it is known that some patients, when they're in their off phase, may have anxiety during that off phase. Next slide. So how do we help manage this anxiety? How do we help manage some of these non-motor symptoms? Well, there's different medications. We call them SSRIs, or selective serotonin reuptake inhibitors. These are medications most of you have probably heard of. Brand names Zoloft, Lexapro, citalopram, Paxil, Prozac. These do take a while to work, however. They take anywhere from about 4 to 6 weeks to really chemically do what they need to do in the brain. Some patients, however, will notice some benefit after about 2 weeks. Another class of medications we use to treat anxiety is called benzodiazepines. These are medications like Valium, alprazolam, clonazepam, lorazepam. We need to be really cautious with this use. The reason for that is your body can get used to these medications over time. So the longer you use them, the more you need and the higher doses required. In addition, long-term use of some of these medications have been known to cause balance issues and even memory. These, however, don't take a long time to work. They work immediately. So I kind of use these as needed sometimes. But what I find is that if you're using a lot of these medications, then we need to better manage through other medications. In addition to medications, how else can we treat anxiety? Well, of course, psychotherapy. There's data that if you combine both medications and psychotherapy, you're going to have a better outcome. A specific psychotherapy that has been seen to be beneficial is something called cognitive behavioral therapy. What this does is it basically takes your thoughts and teaches you how to change your thoughts, and therefore will subsequently change your behavior. There are other things, of course, that can help manage anxiety that people might find useful. This includes massage, meditation, music therapy, and I didn't put it in there, but of course, exercise. Next slide. So this slide actually might be a little bit hard to see. I'm having trouble seeing it. Is there any way to make it bigger? So basically what you want to do is make sure and educate yourself about Parkinson's disease. Maybe keep a diary of your symptoms. Is anxiety at all related to your motor fluctuations or when you're off? Make sure and talk to your provider about anxiety. Again, this is part of the disease. It's a chemical process that's going on in the brain. Come up with some sort of plan to help you cope with your anxiety. And if it's not working, switch gears and try something else. Next slide. So another mood issue that we see, as well as anxiety, is depression. Up to 50% of patients with Parkinson's have been noted to also suffer depression. Again, emphasizing that Parkinson's disease actually causes chemical changes in the brain that causes and puts people at risk for these mood, non-motor symptoms. Know that depression can actually, when it's present, can intensify both the motor and the cognitive symptoms of Parkinson's. So sometimes untreated depression can manifest itself a little differently. So by treating the depression, sometimes we notice that both the motor and the cognition improve. What is depression? Well, it's an overwhelming feeling of sadness, loss of hopelessness, interfering with a person's ability to function. It often lasts weeks or months. I want to just mention that because sometimes people have situational depression, such as when there's a death in the family or when you've had a significant life-altering event, such as a move into an assisted living, etc. Next slide. These also are symptoms of depression I just listed in there. I want you to be aware that usually people don't find enjoyment in things, and this will come relevant with some future slides. But depression is when you're doing something that normally you would enjoy, but you're not enjoying it. It can cause sleep difficulties, too little or too much sleep. It actually can change your appetite. Again, you can have increase in appetite or even decrease in appetite. Next slide. So how do we manage or treat depression? Well, again, just like anxiety, it's often a combination of both pharmacotherapy as well as counseling or psychotherapy. We also find that patients with Parkinson's who experience uncontrolled on-off periods and freezing episodes are more prone to depression, just like anxiety. CBT also has been shown to be beneficial for people with depression. Again, this is a type of psychotherapy. Be aware that often depression coexists with anxiety. Exercise absolutely can help with both depression and anxiety. Of course, we also offer medications, those SSRIs, those serotonin agents we mentioned in anxiety. And then there's another class of medication called SNRIs that also have been proven to be beneficial in depression. These are medications such as venlafaxine, mirtazapine, bupropion. Next slide. This as well just gives you some tips to help cope with your depression. Next slide. Apathy. I get a lot of reports in clinic about apathy. What is apathy? Apathy actually is a lack of enthusiasm, interest in something, or motivation. How does this differ from depression? Well, often apathy can and often does coexist with depression. It can be independent of depression as well. Apathy in general is when somebody doesn't want to do something, but they do it and they end up enjoying it. Versus depression, they don't want to do it. They end up doing it and still don't find enjoyment in it. Apathy can be an extremely frustrating non-motor symptom. I'll be honest, it's probably more frustrating though for the care partners than it is for the patient themselves. Usually a patient with apathy is quite content not having the motivation. Unfortunately, it also has no proven treatment. There's no pharmacotherapy or drugs that can help with the symptom of apathy. So how do we treat it? I think education is one piece, knowing what it is, knowing that it's part of Parkinson's disease. The biggest treatment I usually recommend is a regular routine, setting up a routine. You need to continue to socialize and exercise even if you don't feel like it. You need to make sure and avoid isolation. That will make apathy even worse and perhaps then more at risk also for depression. Next slide. Again, tips to manage apathy. Be social, have support teams, have support groups, make sure you have a routine, have socialization, have exercise plan, make sure you get enough sleep. Next slide. What also is a non-motor symptom? So breathing difficulties. I'm trying to touch on the non-motor symptoms that I find myself not often talking about in clinic. But you definitely can have breathing difficulties as part of a non-motor symptom of Parkinson's disease. Well, when do we see this? We see it sometimes in those motor fluctuations or when people are wearing off. And basically, again, it's just because of the bradykinesia and rigidity of the system. You also can have breathing difficulties when you have dyskinesia. Again, those extra movements that we can see with carbidopa-levodopa use over time. It's actually dyskinesias of the diaphragm muscle that cause the respiratory dyskinesias. Anxiety also can cause breathing difficulties. We've already talked about anxiety in terms of how it can cause symptoms and relate to Parkinson's disease, but know that in the states of anxiety, you tend to have short, shallow breathing. Aspiration pneumonia, of course, can also be, though, however, a complication of Parkinson's disease. In Parkinson's, we can have some intermittent swallowing difficulties over time. Food may be going down what I always call the wrong tube, and you may develop pneumonia. So if you do have breathing difficulties, of course, that is perhaps a possibility and would want to get checked into. Then, of course, there's a lot of different breathing difficulties that patients can have that are not related to the Parkinson's disease. Next slide. So how do you manage these breathing difficulties? Well, I think it's really important to look at what do you experience, and most importantly, when do you experience them? Do you experience them in relationship to the timing of your medication? Are you having other symptoms with these breathing difficulties? Dizziness, chest pain, sweating, those types of things. And of course, you want to let your provider know that you're having these breathing difficulties so we can help manage and try to understand and make sure that there's nothing else causing them. Of course, trying to treat them as well. Next slide. Vision problems. So there's many different vision problems you can have with Parkinson's disease. One thing I see frequently is patients with dry eyes, and that's mainly due to because we're not blinking at the same rate as people without Parkinson's disease. So tearing of the eyes actually is a sign that you could have dry eyes. And it's because of just our autonomic nervous system kicking in and releasing tears. Dry eyes often causes burning or blurry vision. You also can, however, have double vision with Parkinson's disease. And basically, I like to think of it as the eye muscles, or the eye itself is actually connected with eye muscles. And just like you can have slowness of movement in other muscles of the body, you can have slowness of movement in the eye muscles. And due to that, if they're not exactly moving together, so if your eyes aren't exactly moving together because one muscle may be a little bit weaker, your brain will perceive it as double and you will see double. So sometimes we can treat that with optimizing your dopamine medications, but it often does not work. Sometimes patients will notice trouble reading. Again, it's the transfer of those eyes moving together. Let's see. And then every so often we can have trouble voluntarily opening the eye. We call it eyelid opening apraxia, where the eyes kind of want to stay shut and it's hard to open them. We usually see that in more advanced stages of Parkinson's disease. The treatment for that specifically would be Botox injections, which is probably effective about 50% of the time. In regards to the double vision, treatment for that is typically prism glasses if it's bothersome enough. So I'll usually refer patients then to either a neuro-ophthalmologist or an ophthalmologist to help treat that symptom. Dry eyes, of course, treatment for that would be eye drops, lubricating eye drops specifically, and or lubricating eye ointment to apply at night. Next slide. So this kind of already illustrates what I already briefly talked about, but I think it's important that if you do develop vision problems, to see an ophthalmologist regularly. Also, you may get 2 pairs of glasses, one for distance, one for reading. That may become easier. Sometimes those are a little bit better than bifocals. For the dry eyes, again, we talked about moisturizers or ointments, lubricating, artificial tears. Next slide. Fatigue. So fatigue is a big non-motor symptom I often hear about in my office visit. Like apathy, unfortunately, we don't have a great treatment for it. What is fatigue and how is it different than sleepiness? Well, fatigue is a feeling of deep tiredness, but it does not improve with rest or sleep, versus sleepiness actually does improve with sleep. Reports say that fatigue is present in about 50% of patients with Parkinson's disease. I will be honest, I think anecdotally only over the last 11 years, I think it's higher than that. About a third say it's the most disabling symptom. It can be common early in the course of Parkinson's disease, but it can occur at any point. So fatigue by itself does not correlate with disease progression or stage of disease. Fatigue also could be a symptom of depression, but know that a person can be fatigued without being depressed. So it's very important to try to delineate those two because obviously treatment would be different. Stress, of course, can make fatigue worse. Fatigue itself, there's no specific cause that we know for sure that's going on in the brain, of course, to be able to fix it. I think it's probably a combination of what I always explain to my patients, that your body is working overtime to do the same amount of things. So that, of course, is very fatiguing for the patient. Next slide. So again, unfortunately, fatigue, we don't have a treatment for. There's been no proven treatment by itself. Some providers prescribe different medications such as amphetamines. These are medications such as Ritalin used in ADD or ADHD. I do not use those medications. This is mainly due to the potential risk factors of those medications. Those medications can constrict blood vessels. So when we're working in older populations, they do put patients at risk for stroke and heart attack. So they have to be weighed against the benefits versus the risk. I would always encourage patients to talk to their provider about their fatigue and to try to identify any reversible or medical causes for the fatigue. Things like vitamin D levels, if you're low in vitamin D, can cause fatigue, thyroid issues, things like that. So I would always want to make sure that there isn't a concomitant medical issue occurring that is causing the fatigue, and that it is in fact due to the Parkinson's disease. I always would encourage you to talk to your doctor before taking any vitamins or supplements, because a lot of these medications are not regulated by the FDA and they may interact with some of your medications. In addition, of course, a lot of medications can cause fatigue by themselves. So making sure and looking at the medications and eliminating any that aren't needed and that may be causing that symptom. Next slide. So this is just a little schematic, again, summarizing kind of what we already talked about, but different ways that different tips, I should say, or ways that can help you cope with fatigue. These seem really obvious, but I do think that if you comply with these, your symptom can improve. Next slide. Constipation or nausea. This as well is one of those non-motor symptoms that I think goes under the radar sometimes. Constipation is technically defined as fewer than 3 bowel movements a week. Of course, we always want to rule out other causes. I want to emphasize that a lot of these non-motor symptoms I'm talking about, of course, can be seen in the general population and are not specific to Parkinson's disease. So I would not want these symptoms to just be assumed that they're part of Parkinson's disease. Constipation is one of those symptoms that can predate the motor symptoms by many years. There's some data that shows it can even predate the motor symptoms by 10, even 20 years. Constipation by itself can be caused by many different things. It can be caused by the disease itself, but it also can be augmented by medications, stress, lack of exercise, dehydration, lack of fiber in diet. Nausea can be present mainly from delayed and gastric emptying. So we know that as Parkinson's goes on, the stomach emptying can be more delayed and unpredictable. So with that can cause nausea. I often see this as what we call early satiety, which just means you have a meal and you get full fast and you start to feel nauseous. Treatment of this, of course, would be to rule out other causes for nausea, as always. But to eat smaller, more frequent meals can help with this early satiety or getting full and then therefore nausea. Next slide. So how do we cope with the constipation and the nausea? Well, I alluded to this a little bit earlier, but basically you want to eat a well-balanced diet, plenty of fiber. I often urge my patients to drink at least about 5 cups or 5 8-ounce cups of water each day. You need to perform some kind of exercise daily. You want to add fruits, vegetables. Of course, these are high in fiber. Sometimes patients need to add foods such as prunes, bran cereal, prune juice. The three juices that are known to help with constipation, we have prune juice, white grape juice, and apple juice. Sometimes if you've done all that and it's not enough, you need to take a mild stool softener or laxative. There are a lot of studies done on the different agents we can use to help with constipation. Miralax I put on there mainly because that seems to show the best evidence of benefit in people with Parkinson's disease. I've already talked about the smaller and more frequent meals that are sometimes necessary to help with that nausea feeling, especially after you eat. Next slide. Skin changes. What types of skin changes can we see in people with Parkinson's disease? Often people can have a type of oily or flaky type of inflamed skin. We call it sebaceous dermatitis. It's usually on the top of the head or the scalp. We also can see it across the forehead and on the sides of the nose. It usually can produce these little scales that they're white and they're flaky and yellowish and oily. They can itch and they can cause some redness. What are the treatments for the skin changes we see in Parkinson's? Obviously, you want to wash your skin at least twice a day, just with warm water, and rinse with cold water. Use a neutral soap. Don't use any perfume or heavy soaps. They tend to make it worse. If you have this on the top of your head, dandruff shampoo can help. Usually those agents contain some selenium in them. In severe cases, however, doctors can prescribe different prescription shampoos or lotions containing these items. If it's bad enough, I usually will send my patients to a dermatologist for that. Next slide. Excessive sweating. Again, one of these non-motor symptoms that I think people have but don't necessarily always mention. What is the cause of excessive sweating? Well, again, because the autonomic nervous system can be involved in Parkinson's disease, the autonomic nervous system helps regulate sweating and temperature regulation. So people with Parkinson's can have trouble with temperature regulation. It can be associated with some medications, or it could also be an off symptom. So you want to notice, again, when do the symptoms occur? What are the treatments? Well, obviously, if you tend to overheat, you don't want to dress too heavily. Maybe take lukewarm showers instead of hot showers. Wear lightweight clothing. I often warn my patients, make sure and stay hydrated if you're sweating excessively. Sometimes patients will have excessive hand sweating or bottom of the foot swelling. We can apply different topical agents if that is bothersome enough. Some of the medications I find to be bigger culprits of this is some of those SNRI medications that we can use for depression, the venlafaxine, mirtazapine. In addition, dopamine agonists, which Kelly will talk about later, some of those medications as well can cause this excessive sweating. Next slide. Micrographia, again, that's just smaller handwriting. How do we help manage this non-motor symptom? This symptom will not always improve with dopamine medications, although it can. Practice, write. Use a weighted pen or pen with a thick grip. Also, I encourage patients to print more than cursive write. Printing will be easier. Maybe use lined paper to keep you on track. Take breaks, and then of course do the majority of your writing during on time if you can. Next. Urinary symptoms. What are the urinary symptoms that we can see in Parkinson's disease? Usually it's a frequency and an urgency, as if I have to go now. The bladder may not even be full. How do we typically treat this? I usually give my patients a referral to a urologist. Again, I want to make sure that no other reason for the urinary symptoms before I just say that it's due to the Parkinson's disease. There are ways that you can train your bladder by taking scheduled bathroom times. There actually is physical therapy for the bladder. You can use biofeedback, again, to try to control your bladder muscles. There are medications, again, to help with some of that bladder spasming that we can see in Parkinson's. Next slide. Weight management, weight loss. So usually this is from the disease itself when you get weight loss. Usually it's a gradual loss. It can be due to many different causes. Again, if you don't have your sense of smell or taste, sometimes that affects eating and it's not as enjoyable for you. Excess movement. Of course, if you have more dyskinesias or tremor, your metabolism is increased. You're insensible, so you're losing some weight there as well. Some patients will have swallowing difficulties, or it's so laborious to eat. It takes so long, they get fatigued, and so they don't eat full meals. Some of the other non-motor symptoms that could affect your weight and cause weight loss: depression, anxiety as well. So by treating those can help with weight loss. As always, I want to make sure that the weight loss isn't due to something else. Next slide. How can you gain weight if you are losing weight? So again, eat smaller, more frequent meals so you don't get exhausted eating larger meals. Eat foods that you enjoy. Save your energy for eating by keeping easy to prepare foods. Season foods if you can. High calorie foods. As long as you don't have other medical issues that keep you from eating other things, even ice cream or calories, we don't want to lose too much weight. Weight loss can affect the ability to fight infections. Consider drinking supplements such as Boost, Ensure, Carnation Instant Breakfast. Next slide. Well, with weight loss, you also can have weight gain. However, with weight loss, it's usually part of the Parkinson's itself. Weight gain is going to primarily be from the treatment of symptoms of Parkinson's, so the medications or therapies. It's not uncommon after patients get deep brain stimulation for them to gain weight, and it's probably because we're controlling their symptoms better. Dopamine agonists, the pramipexole, ropinirole, can cause weight gain specifically. In addition, psychiatric medications can cause some weight gain. Next slide. So in summary, when we talk about Parkinson's, we often focus on the motor symptoms and treating them with dopamine medications. However, there is a multitude of non-motor symptoms. And I find often that those non-motor symptoms can affect your quality of life even more than the motor symptoms. Some of them are difficult to treat. Some of them are easier to treat. However, there always are ways to help you cope with those symptoms. Know that they could be part of your Parkinson's disease, but not necessarily. So it's very important that before you just assume it's part of your Parkinson's, is to talk with your provider and rule out other causes. I always encourage my patients, talk about your symptoms with your provider. Get knowledgeable about Parkinson's and all the different symptoms that are possible. I often tell my patients, Parkinson's has so many flavors. So not all of you will experience the same bothersome motor symptoms, and not all of you will experience the same bothersome non-motor symptoms. I do encourage everyone, however, to be very proactive in your disease. Next slide. So for those of you that play cards, I know Wisconsin, we like to play cards sometimes. I often say, so you've been dealt this hand, how are you going to play it? How are you going to cope? How are you going to work with your symptoms day to day? Next slide. All right, questions?
Hey, Dr. Spangler, it's Jeremy from the WPA. How are you today?
Good, how are you?
I'm doing good, thank you. We had a couple questions submitted, so I'm going to read them off to you and kind of get some input from you. But first of all, thank you so much for the presentation. As I've told other presenters, I'm sure if you listen, you can hear the round of applause going on. It's really amazing. It's just awesome, so thank you. Vance posted a question. He said, I can't keep my eyes open. I've had trouble. My doctor's tried Botox injections with that. That hasn't worked, and I continue to have issues. Do you know of any other treatments or ideas that might help with the eye issue?
So I've seen that. So I'm going to assume it's a eyelid opening apraxia, like I mentioned. Botox is probably the first line. So I would want to make sure that the Botox Injections were optimized and really needed to be at a dose that he responded to. The other thing is that there are other treatments that can exacerbate the eyelid opening apraxia. I don't know if this person has deep brain stimulation, but DBS has been noted that the treatment actually can make that a little worse. Or is it part of a dyskinesia? So by cutting back on the medications or the stimulation, it also may be able to help with that.
Perfect. Thank you very much for that. One of the other non-motor symptoms that I don't think you touched on a whole lot that a lot of questions came in on were sleep issues. How often is sleep impacted with Parkinson's disease? And then what can maybe we do to help address some of those sleep issues?
So yeah, I apologize. I didn't get to touch on sleep, but as you know, in years past, we were able to devote a whole hour to sleep. So there's a lot of different sleep issues that can occur in Parkinson's. I would say probably 50 to 75% of patients have some sort of sleep issue. And again, it depends on the sleep issue, depends on the treatment. I find one of the biggest issues I hear about in clinic is that of what we call sleep fragmentation. And it's where you just have frequent arousals at night. And for me, it's normal to have 2 arousals per night for anybody over the age of 65. The important thing, however, is are you able to fall back to sleep? And if you're not able to fall back to sleep within 30 minutes, then that's a problem. So if you're having a couple arousals of sleep, but you're falling back to sleep, I wouldn't view that as a problem. However, if you're not, then I would recommend trying to analyze, why are you waking up? Are you having jerks in your sleep, such as periodic limb movements? Are you snoring? Are you having apnea issues? So I then usually would send somebody for a sleep study or to sleep medicine or a sleep specialist to try to analyze that. So that's if you're waking up periodically. However, if you have trouble falling asleep originally, or even if you wake up in the middle of the night and have trouble falling back to sleep, there are medications that can help with that. I'm kind of a minimalist, so I usually start with something mild, but that's been proven to be of benefit, called melatonin. So melatonin can help people fall asleep and helps regulate their circadian cycles. It has been studied in Parkinson's and is relatively safe. The only potential side effect I see is perhaps a little bit of what I would call a hangover effect in the morning. So I hope that answered some of the questions.
Absolutely. And then I'm going to finish with one question, a final question, I guess is the best way to put it. You touched on, fatigue, urinary issues, constipation. What is the caregiver's role in the doctor's appointment when they're seeing some of those issues within their spouse? And how do they address those with you and their spouse to make sure that we're looking at, is this a Parkinson's issue, or is it just and we're getting older and certain things aren't working the way they're supposed to issue?
So my answer often is a generic answer, but it kind of depends. But I find most caregivers are very much involved in the care of their loved ones. And so I always encourage, of course, I always want to listen to the patient, but it is important that the care provider also gets to weigh in on some concerning symptoms that they've seen. So I think it's always good to prepare a little bit for your office visit, to kind of, whether it's on the drive into the office visit or something, but really sit down and kind of write down your concerns. So it's less of a surprise. It's something you've already talked about, and then it can make the visit more productive.
Thank you so much for your time and for your answers. I know everybody appreciates it. I know in the comments, a lot of people are saying thank you. So thank you very much for your time in doing this.